My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you're interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
Dr. King, thank you so much for being with us tonight.
Of course, my pleasure.
So we brought you on to discuss specifically craniosacral manipulation. So first of all, we're going to do this episode a little bit different, but we usually talk about your journey. And I really want to spend time talking about cranial therapy. Can you just tell us a little bit about your position now and what your practice looks like and what your day generally looks like?
Sure. I'm half-time at the University of California, San Diego School of Medicine. In the clinics there, I am administratively billeted in the integrative medicine service, and there are myself along with 6 other DOs have the OMT service. We do outpatient OMT and inpatient OMT in the University of California, San Diego Health System. And then I have, according to a third of my time, I'm in private practice at the Osteopathic Center of San Diego. I have had a private practice for many years. This is where the Osteopathic Center for Children is. The place in the private practice was started by Dr. Viola Fryman, who was a well-known cranial osteopath and pediatric treater, and worked with her for many years. She was my main mentor in the cranial concept. And then I have a number of research projects, all of which have utilized the cranial concept. One is OMT for Parkinson's disease. Then I have one in the Department of Ophthalmology on OMT to lower intraocular pressure, which really emphasizes the cranial treatment. And then for traumatic brain injury, I have a third study that's all IRB approved, and we are getting good results in reducing the migraine headache experience of people that have had concussions, mild traumatic brain injury. And then I'm working on a study on plagiocephaly, which is the babies born with the crooked heads, and the application of the cranial treatment marvelously, naturally restores the children's cranial bones to their normal symmetry without the use of the helmets therapy, and that's a controversial element. So I have the clinical work and the research, and that's been my path for a number of years. I use the cranial procedures in 100% of my patients. I do other types of treatment as indicated. I even do HVLA on occasion, or muscle energy. The strain, counter strain are the types of things that I would do in addition to the cranial. Technically, nowadays, the cranial concept was introduced by William Garner Sutherland in the late 30s and 1940s. And it's been a part of the osteopathic armamentarium of treatment ever since. It's not that widely known because many of the colleges of osteopathic medicine don't have faculty that are comfortable with utilizing the cranial and to even teach it. I wish more of the medical schools would get someone like me to come and give a 1 or a 2-day seminar on the cranial concept so that there could be a good presentation of it. Right now, the Osteopathic Cranial Academy is a component society of the American Academy of Osteopathy. And if all the students and residents don't already know it, if you have an interest in doing any kind of the manual medicine that we call osteopathic manipulative treatment, we do have specialty societies that give a lot of continuing medical education courses in the area of the manipulation. And then in the Cranial Academy, we sponsor a lot of courses in the cranial concept. So the teaching is not that hard to come by. And I hope that the students in the 4-year curriculum somewhere, if they're interested, there are scholarships available through the various cranial courses around. Dr. Steve Blood, who you might know of on the East Coast there, he just recently passed away. For years, he and Anthony Capobianco had a cranial course, I think, at NICOM, and maybe at the Philadelphia School as well. So there were these folks that sort of spread the word about the cranial concept.
It's funny when I went to NICOM, and I actually did take some classes with Anthony Capabianco, and I'm dating myself because I've been out about 15, 20 years now, but he used to have classes sort of up in his attic where it was very interesting. The name of our podcast is Do or Do Not. I'm obviously a Star Wars fan, but I always view cranial manipulation as sort of a Jedi order. As you alluded to, it's a very specific branch of osteopathic medicine. There are places that you can learn the techniques, but you really have to seek out this very special training. Do you think that's right?
Yes, I know out of St. Barnabas, Hugh Ettlinger is a leader in the cranial work. I think he's still a residency director there. They have a number of really good cranial osteopaths in that area. Zena Pelkey, in particular, Hugh, and I know that the neuromusculoskeletal medicine residents there all have an opportunity to develop their cranial palpatory skills. So, I know they're in the New York area. You're aware of St. Barnabas and Hugh Ettlinger. I know that at NICOM, it's several really good. Who does cranial at NICOM these days?
I'm a gastroenterologist, so I don't know that I can answer that question, but I'm going to go down other paths. We have some medical students listening. Of course, there are osteopathic students and residents listening. So if a medical student's tuning in and they're thinking, why is Storch talking to Dr. King about cranial manipulation? I don't even know what this is. Can you just give a basic layman's discussion on, I guess, the physiology, the anatomy, and what the philosophy is in treatment?
The 5 phenomena of the cranial concept are that the membranes of the brain and spinal cord move. And there's a rhythmic component to that. The research is actually pretty good about showing that the cranial bones do move. And it was NASA that started this research. They were worried about the astronauts going out into space and not being able to maintain consciousness. And they developed technology that actually measured the biparietal diameter, the anterior posterior position of the cranial bones. And it moved, 500 microns to a millimeter. So the cranial bones are compliant. They allow for the changes in the intracranial fluid volume. The biomechanics are that the brain and spinal cord have a protective membrane around it, the dura mater. This is a fibrous membrane that will bend like a garden hose, but it doesn't stretch hardly at all, and it's firmly attached in a number of places inside the head. One of the main areas is at the foramen magnum, and then the dura mater continues as the protective membrane around the spinal cord, clear down into the sacrum, and it's fairly firmly attached at the second sacral segment. And this motion that is driven by the changes in the intracranial fluid volume makes the cranial bones move, and it puts a pull on the dural membrane, making the sacrum move. And that's why it's called the craniosacral, is that you have palpatory biomechanical movement that's measured in the cranial structures and at the sacrum. So there is, that's the main neuroanatomy, the mobility of the cranial bones. Who hasn't hit their head? Who hasn't fallen and, got a black eye, or, done a header in soccer, or played football and had, a helmet hit in the head? The cranial bones absorb all of these kinds of traumas. And so the alignment of the cranial bones do get out of whack. And the cranial techniques allow you to restore the intended alignment of your cranial bones. There's been a study done on palpating the cranial rhythm, and it turns out that lay people who never heard of it, but just said, come and feel this motion, they feel it just at the same rate of perception as an osteopathic student. This was a study done in Europe. My point being that you don't need to study it to feel the motion. It is controversial because the concept holds that the cranial bones move. And that is not universally accepted by the anatomy faculties in all the medical schools. However, the evidence is really building up that it does. I've written several articles on this. I think the main reason that it's hard is that the first time you try to feel the cranial motion, most people don't feel a whole lot. But it's a skill that you build, not unlike learning to read Braille. Necessity is mother of invention. And if you really practice it, you can learn to feel these motions. You can detect, for instance, the compression between the sutures in the head. One of the things that I get a lot of success in are earaches in the children. And usually that's a compression of the occipitomastoid suture, the joint between the temporal bone and the occiput. And that suture can get compressed from a blow to the head. And this actually changes the orientation of the temporal bone. And it pulls on the eustachian tube, blocking it up. And so you get then the accumulation of the fluid in the middle ear and you get an ear infection. And we've got some good research that shows that treating the children with otitis media really is effective by restoring the normal position of the temporal bone and thereby the anatomy of the inner ear, particularly the eustachian tube. So this is really a worthwhile kind of thing. And the cranial concept practitioners, there's been research showing that if you can identify the temporal bones that are out of position, that the chances are the youngster either has had or will have a middle ear infection. So that's just one of the really practical examples of using this kind of treatment. In my own practice, I had 3 people with headaches today, and they had various bones of the head that were compressed. And the main place where the headaches get you is where the head sits on top of the vertebral column, the occipito-atlantal junction. And there are cranial procedures specifically for the decompression of the occipital bone and the condyles of the occiput that rest in the little grooves of C1. Check out the anatomy. It's there. And practitioners like me just use that anatomy. You know, what do you remember from your freshman OPP class? Anatomy, anatomy, anatomy. So if you know your anatomy, you can figure out all of this stuff.
In your practice, would you say that the majority of patients are coming to you for primary treatment of their disorder, coming to an osteopath that practices craniosacral therapy? Or do you find that the majority are patients that maybe failed, quote unquote, standard modalities and are not getting relief? What type of patient comes to see you for treatment?
I think in a general osteopathic manipulation practice, you get the folks that have failed in other types of treatment. For my present practice and for the last 30 years, I've been pretty much an OMT specialist and a cranial specialist together. And I get referrals for the tough to treat, the ringing, the tinnitus, the vertigo, things that conventional medicine has not been able to help. The medicines don't help that at all. And the cranial treatment gets at, as I was talking about earlier, about the alignment of the inner ear and the cranial nerve 8, the nerve that supplies both the position in space from the semicircular canals and the auditory input from the cochlea. Somehow a derangement of the temporal bone twists, pulls and deranges that. And the cranial treatment has the potential to realign that and restore a normal balance and auditory function.
First of all, that's amazing. Like, I appreciate everything you said about cranial manipulation. I want to go back and take a class. Although I don't know that patients under propofol having a colonoscopy would really benefit, but you never know. But let me ask you, how did you end up on this path? You're family practice trained. Can you run us through a little bit your journey of how you ended up at osteopathic school and how you became so passionate about OMT and ultimately craniosacral?
I have a very unusual path, Dr. Storch. In a Reader's Digest paragraph, I am a Ph.D. clinical psychologist first. I was a psychotherapist. I did my Ph.D. dissertation on dreams. And I had a dream about going to osteopathic medical school. And so it always kind of stuck with me. And I was able to finally, at age 35, be admitted to the Texas College of Osteopathic Medicine. And during my freshman year, Dr. Haricall, who was the then chairman of the OPP department, and he was also the president of the Sutherland Cranial Teaching Foundation, which is one of the main organizations providing education in what we call osteopathy in the cranial field. And in my freshman year, I kind of heard the lecture about cranial, halfway slept through it, but I heard about it. And the next day, I take my daughter to the dentist. And this is 1979. And my daughter, the dentist, so she's got a class 2 malocclusion. Her jaw is really crooked. She's going to need orthodontia. Well, in those days, I didn't even have medical insurance, much less dental insurance as a freshman in medical school. And I remember Dr. Haricall talking about this cranial stuff and how it could fix teeth. And so I approached him and I asked him, could you treat my daughter? He said, no, my schedule's too full. Bring her to the class. She'll be a pediatric demo. Oh, God. Dress this cute little 7.5-year-old girl up in a nice dress and take her to the class. And Dr. Haricall says, okay, student, Dr. King, what's your analysis of her head? Oh, man, I wish I'd listened to the lecture. You know, it was
All right.
I got it half right, and he sort of took pity on me. And he showed me what was wrong with her head and how to fix it. And one of the main techniques was to do what's called a Vomer pump, V-O-M-E-R. And you put your finger on the roof of the mouth and you pump it, and also do the decompression at the occipital junction. So I did that on my daughter at bedtime for about 10, 12 months. We go back to the dentist. The class 2 malocclusion is gone. And he asked me, what did you do? And I said, well, I did that cranial work. And the dentist said, oh, that Dr. Haricall who does the cranial plate stuff. I said, yeah, that was it. Well, that imprinting and saving thousands of dollars of orthodontia convinced me that there was something to this cranial concept. And so from that point on, I took every opportunity. This was in Fort Worth, and in Dallas at the time was a practitioner named Roland Becker, who was the successor of William Garner Sutherland as the leader in the cranial concept. And so I was able to get some really good training. And then after I finished my internship and came back to San Diego, Dr. Fryman looked me up and offered me a position because she knew I'd been trained in the cranial concept by this Dr. Haricall and Dr. Becker. So I just naturally fell into it. It's been a wonderful career. I mean, I'm really glad to have an opportunity to talk on your podcast because at least maybe we can stimulate some of the students and aren't that familiar to pursue it a little bit more. For me, it's not woo-woo at all. And that's been the problem, being accepted. They think it's too mysterious. You got all these things, cranial sutures and this rhythm that no one can measure. Well, now you can measure it. And so it makes a great deal of sense. I personally think there's a procedure in the cranial concept called the compression of the fourth ventricle. And I want to put that out big time right now in your podcast. It's a procedure where patient's head is resting in your hands over the meaty part of the thenar eminence of your thumbs, right medial to the external occipital protuberance. And basically, it relaxes the patient. There's a lot of research on it that shows it improves sleep latency and sleep duration is improved. You are more relaxed. It reduces sympathetic muscle activity, but it gets the cerebral spinal fluid flowing. And we think this is a way to prevent neurodegenerative diseases, Alzheimer's, multiple sclerosis, Parkinson's, dementia, if you can get the cerebral spinal fluid flowing through the ventricles in the brain to literally cleanse out the waste products of cellular metabolism. That they tell you all these Lewy bodies in Parkinson's, beta amyloid plaques and Alzheimer's, tau protein and dementia. You give the brain an enema by increasing the cerebral spinal fluid flow. On rats, this has been done. We figured out how to do a compression of the fourth ventricle on a rat, and we had these 12 Alzheimer's rats. 6 got the compression of the fourth ventricle and 6 did not. And the ones that got the cranial treatment, they ran the mazes faster. And then when you sacrifice them and analyze the brain, the ones that got the treatment, they had far fewer of the little plaques of the beta amyloid, and they had a lot more neurotransmitter in their brains. And the 6 Alzheimer's rats were just typical, they all died. I mean, they were sacrificed, but they would have, continued with the Alzheimer's condition. So for me, the cranial concept has an awful lot to offer in the neurosciences. We think it also makes the GI tract work better, Dr. Storch, by the vagus nerve, cranial nerve 10, what passes through the jugular foramen. The smart people always say, well, it's cranial nerves 9, 10, and 11 pass through the jugular foramen outside the head. And they all forget to say the jugular vein. I just love it. Like, who's buried in Grant's tomb? Jugular vein comes through there. But it's cranial nerve 10, which is the innervation of the parasympathetic nervous system. And one of the main things the parasympathetic nervous system does is it's the peristalsis of the GI tract. And you can really help the motility and peristalsis by making sure that the vagus nerve is not impeded at the base of the skull in the jugular foramen. And the cranial treatment does a very good job of that. So the cranial concept affects, I lower interocular pressure by getting the canal of Schlemm and the trabecular meshwork around the eyes working better with the cranial treatment. We help people with the GI tract work better. It's really good, in reducing constipation.
Do you think that bringing cranial into the spotlight, so to speak, that an important factor is more research proving the concepts, both clinically and basic science?
Yes, and we're on the brink of that. There is MRI technology. It's called arterial spin technique. And basically, you can measure the intracranial fluid volume. You can measure how different brain centers are affected by the cranial. And what we're finding is that the pain centers are affected, and you can measure that. And this reflects the changes in the cranial manipulation between those who get the cranial and those who don't. The brain centers light up in ways that do explain what's happening in the brain in terms of the pain reception and then the effects of how you improve the body through the manipulation. So gradually, we are understanding what the cranial techniques are doing inside the head. And I think technology will prove it. I've been trying to get a grant to really explore the degree to which this compression of the fourth ventricle increases the cerebrospinal fluid flow. I showed this to one of the neuroradiologists at UCSD, and he was impressed. And I asked him, will you collaborate with me on a grant proposal? And he said, no, I don't have time. He said, this is interesting, but he didn't want to be a groundbreaker. And that's been my problem. I would encourage all the students listening to this, when they're in radiology and they're studying the different kinds of things that MRIs can do. And if you think about you want to go into neurology or neurosurgery and you wonder about this cranial stuff, just bring this up. A resource that I have leaned on heavily for the cranial research is a neurosurgeon out here in California at Arrowhead Regional Medical Center. His name is Dan Muley. He has a neurosurgery residency, and he's published several articles on the cranial treatment. And one of the most recent ones he did was badly injured, mild traumatic brain injury folks. They can measure the optic nerve sheath, and it's all inflamed and swollen from the head injury. And after 6 treatments of the cranial, that optic nerve sheath is back to normal, and the traumatic brain injury person is improving. My point being that the technology is there, and there is this one place out here in San Bernardino, California, that's doing some research on it. The other place, believe it or not, is Italy. The Italians are big into the cranial concept. So I've been to Italy to teach about a dozen times the cranial there.
First of all, thank you so much for your time. You've been amazing. If there are pre-medical students or medical students or residents listening that want a book to start with to read a little bit about cranial, or if you could just give us some resources that you would recommend for sort of a neophyte that wants to start on a journey into cranial manipulation.
I'm going to give a shameless plug for myself.
Love it. Do it.
Foundations for Osteopathic Medicine, the 4th edition. The chapter on the cranial concept is in there, and I wrote it. It's about 3.5, 4 years old now, but it's a good place to start for the good overview of. It's now, by the way, the Journal of Osteopathic Medicine calls what I do Osteopathic Cranial Manipulative Medicine, OCMM. It used to be OCF, or Osteopathic Cranial Field. If you can find it in a medical school library, it's in 1967. It's the title of the book is Osteopathy in the Cranial Field by Harold I. Magoon. It's probably the initial Bible of the cranial concept. Osteopathy in the Cranial Field, and then the Foundations of Osteopathic Medicine, the 4th edition, edited by Seffinger. The internet is just full of all sorts of people, non-physicians in particular, who practiced craniosacral therapy. The John Upledger, a DO, started craniosacral therapy, and basically this is a treatment that's similar to the cranial osteopathy that's practiced by chiropractors, physical therapists, body workers, and so on. The non-physician folks who they have a skill, have a palpatory skill, but they are not physicians. And that's the difference between craniosacral therapy and what we call this osteopathic cranial manipulative medicine. That's a semantic thing. When people call what I do craniosacral therapy, I say, fine. I'm not bothered by that. It depends on who's doing it, a physician or a non-physician. I, of course, would recommend a DO. There's actually about a dozen MDs who have seen the light of cranial, and they have studied it. They have taken all the cranial courses, and they now are excellent teachers. There are some MDs that do it as well. The Cranial Academy has a website out here where I work. It's called the-promise.org. This is the website that we've built up around the work of this Dr. Freiman. And we have a lot of courses, particularly cranial courses that we offer. We have scholarships. If you can get away from a rotation when we're teaching, you can get most of the tuition covered. You just got to get out here to San Diego and lay on the beach after the course. And it's in July, and it's right around the time of Comic-Con. You ever heard of Comic-Con?
I go to Comic-Con here at the Javits Center, but my dream is to come to Comic-Con. So maybe I'll come do a cranial course and go to Comic-Con.
That's the Mecca in the San Diego Convention Center. Oh, gosh.
You guys have the big one. Yep.
Yeah. Dr. Storch, thank you so much for thinking of me and your podcast.
Again, we really appreciate your time. You've been great.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.